So we do indeed, we'll move straight on now to the roundup session. And it's a great pleasure and honour to introduce Professor Tom Bird, who'll give us a historical perspective to start us off. Tom's name is strongly associated with HD research and care, and we have Patrick White to thank for the contact with Tom, Patrick having spent time as a trainee with Tom. So Tom is a neurologist, now retired, and was a member of the University of Washington Medical Genetics faculty for 35 years and founded their Alzheimer Research Center. He maintains a major interest in a broad range of hereditary diseases of the nervous system, continuing to provide scientific and clinical advice to various foundations, and he's maintained a career-long interest in Huntington's. So thank you very much, Tom, for joining us. And we're very much looking forward to hearing your historical perspective.
Thank you for that introduction. Let me see if I can start my slides.
Okay, now.
Yeah, they're coming up. We just need them in presenter mode now.
Slideshow.
Perfect.
There we go. Are we on?
Yes, that's perfect, Tom.
Good. Thank you very much. Welcome from Seattle in the shadow of Mount Rainier. I've titled my talk 5 Decades of Huntington's Disease. You'll see why I said that in a moment. I'm not going to say anything that I think is new to the audience, but I think it's worthwhile stepping back and thinking hard about what exactly is this disease that we are trying so hard to treat and cure and prevent. What does it do to individuals? What does it do to their families? And what does it do to society by and large? I remember extremely well the very first patient I saw with Huntington's disease. It's this man with the red arrow in this pedigree. I saw him when I was a neurology resident in 1969. So that's 52 years ago. That's where that 5 decades comes from in my title. Several years later, when I became a medical genetics fellow, I saw his son who had Huntington's disease. And several years after that, I saw his 2 grandsons who had developed juvenile Huntington's disease and both died in their 20s. It was a fundamental experience for me to see this family and to realize what a devastation this disease could be, not only for a single individual, but for multiple generations of a family over many, many years. I went on after this in my career to see and evaluate and care for more than 1,000 people with Huntington's disease. And I must say, as a neurologist, I came to the conclusion that this was the most remarkable neurological disease that I ever dealt with in terms of the incredible manifestations, the variety of manifestations of the disease. I never ceased to be astounded at what this disease did to patients, families, and society. When I retired from my clinical practice, therefore, I decided to write my experience with these patients and with these families. And this is my book, Can You Help Me? Inside the Turbulent World of Huntington's Disease, that was published in 2019. And the title of my book comes from my experience with this institution. This is the Washington State Penitentiary in Walla Walla, Washington. And in the early 1980s, I received a letter from an inmate in this penitentiary. It was in pencil on a scrap piece of paper. And I'll never forget, it started out by saying, "Can you help me?" And he went on to say that he had the diagnosis of Huntington's disease, that he was in the penitentiary, that he felt he was being abused, particularly by the other inmates around him because of his disease. And if he ever got out, he wanted to know if there was a clinic he could go to that knew about Huntington's. That's exactly what happened. He was eventually discharged from the penitentiary on parole. He came to our clinic, we saw him, we evaluated him, we cared for him for several years. But unfortunately, he turned out to have an obsession and a compulsion with stealing. Isn't that interesting? But he did. He could not prevent himself from stealing. He went on and did it. He was caught, and he went back to this penitentiary where he eventually died. But I've never forgotten that penciled note that I received from him. Can you help me? And of course, that's the question that all Huntington's patients and their families ask. And this experience also made me realize how often, at least in this country, our patients with Huntington's run into the legal and mental health care systems. They're constantly bumping into the police, to jails, to prisons, emergency departments, state hospitals, lawyers and attorneys, government agencies, courts and judges. They always seem to get entangled in these institutions, primarily because of the problems they have with their behavior. This, for an example, is a man who had been a felon. He had been in prison. He got out, and he was shot and killed in a shootout with the local police. And his family called the coroner, who was doing the obligated autopsy on him, and said, save a sample of his blood because his mother died with Huntington's disease. He has a small child, and we, the family, want to know, is he carrying the mutation for Huntington's? Is that child of his at risk or not? And it's fascinating to realize the problem this was for us in the clinic. Did the coroner save the blood sample? Who owned the blood sample? Who was the patient? Who was asking for the test? Who was going to pay for the test? Who was the patient? And who were we going to give the information to? It turned out the family was very wise to do this because, in fact, his blood sample was collected by the coroner. It was sent to our university lab, and it tested positive for the expansion. And so his child was indeed at risk. This is a very beautiful park in the city of Seattle. And I show this picture because the body of one of our patients was discovered in this park one day. And it turned out that this patient with Huntington's disease had been shot and killed by his roommate and then robbed, and his body dumped in this park. And it really brought home to me how vulnerable our patients were because of their lack of judgment, the people they interacted with, the problems they were having, and how dangerous that this could be in their lives. It also turned out at about the same time in this same area, one of our Huntington's patients, with no motivation whatsoever, shot and killed his roommate. And he never gave any reason for it. And I was really caught by the phenomenon of sudden impulsivity in people with Huntington's disease and how that can lead them into tremendous problems. It also left the legal system with the issue of, was he not guilty for reasons of insanity? This is the Creedmoor State Asylum on Long Island in New York, where Woody Guthrie died. And at one time, this state hospital had 7,000 patients, a city within a city. It's now closed. This is our equivalent in the state of Washington. This is Western State Hospital, our state institution, which at its peak had 3,000 patients. And in the first half of the 20th century, hundreds of patients with Huntington's went through this hospital. Many of them stayed there for the rest of their lives. This is the pedigree of one such family. The person Agnes, down in the fifth generation, individual number 3, was a person I saw in our Western State Hospital. And what was remarkable about her family history was look at all the individuals over 5 generations of this family that were in state hospitals, an asylum in Ohio, in South Dakota, in a place called Eastern State Hospital. On the other side of our state is another state hospital, an asylum in Pennsylvania. All these individuals in this family were admitted to and usually died in state hospitals. That's no longer the case. Most of these hospitals have either been closed or greatly reduced in size. The problem in our country is our mental health and medical health system has not caught up with the slack of what you do with the people who years ago would have gone into a state hospital are now outpatients living on the street or living in their homes. We're not really good at caring for them, and the system has not been effectively set up to do that job. I've also been impressed with the problem with embarrassment, injury, and neglect for our patients with Huntington's disease. I think you're all aware of the fact that because of their movements and their behavior, they're often misinterpreted as being intoxicated, and they have a tremendous problem with falls and trauma. For example, here's one of our patients who fell on her stairs at home and suffered a very significant subdural hematoma, had to be admitted to the hospital, have burr holes by a neurosurgeon, and have that subdural removed. She survived, but was never quite the same afterward. And I would point out that our group has just published this paper in the Journal of Huntington's Disease. It just came out this month, titled Subdural Hematoma as a Serious Complication of Huntington's. And we review 25 patients with Huntington's who suffered a subdural hematoma. And 2 of them died because of the subdurals. They were large, they were bilateral, and their lives were unable to be saved. But I think falling, head trauma, subdural hematoma is an under-recognized problem in the Huntington's community. The fact we could find 25 such cases shows that it's not rare. And the neglect of Huntington's patients who don't have a strong support system can be very worrisome. This is the picture of the back of a man who was brought to an emergency room in Seattle. He had Huntington's disease. He had been in an adult family home. His body was covered with cigarette burns and with bruises and abrasions. You can see that he had lost a tremendous amount of weight. He was malnourished, and he actually died a few weeks later. The adult family home was closed and lost their license, although nothing further was done. But it really shows how our patients with Huntington's can be abused and neglected if they don't have a good support system surrounding them. I also have a chapter in my book called We Just Want to Have a Child, and it talks about Huntington's families either giving up people for adoption or adopting someone with Huntington's into the family, prenatal diagnosis, pre-implantation diagnosis, but also a discussion of juvenile Huntington's disease. And this is my favorite juvenile patient. This little girl developed her first signs and symptoms of Huntington's when she was about 6 or 7 years old. She was very shy, and she had a great deal of trouble interacting with her peers. She very fortunately had an extremely kind and thoughtful teacher in elementary school who brought the classroom around to understanding that she had Huntington's disease. They talked about Huntington's disease, and they made this booklet. This is the cover of the booklet, which they titled Princess in Pink. And every one of her classmates contributed a page to the booklet where they drew their own picture of her and wrote a paragraph or so about how much they liked her. This is an example of one of the pages from the book in which her classmate was showing how strong she was. But this shows the value to our patients of having a good support system. The fact that she had this wonderful teacher who brought her into the community and supported her made a huge difference in her life. She went on to die at age 15, but these years in 4th, 5th, and 6th grade were very important to her. And I thank her teacher and her peers for helping her so much. I also have a chapter in my book called Reservation Blues. And we have seen a number of families in Washington who are Native American. These two brothers at the bottom of the pedigree with the red arrows, they both have Huntington's disease, and they are Native American. And they lived most of they're now in a nursing home, but they lived most of their lives on a Indian reservation that had very limited resources. And so they had an extremely difficult time. Their mother had died of Huntington's. But in our Native American families, we often try to sort out where did the mutation come from. And as in this family, at the top of the pedigree, as you can see, we almost always were able to discover that it was a white person, a Caucasian, who introduced the mutation into the family. And I think, in fact, there's evidence that the Huntington mutation in North American Native Americans is very, very rare. And because I'm a neurologist, I often have had to compare Huntington's disease with other diseases. And I think there are several that it's very similar to. It's certainly similar to schizophrenia in terms of the patients with Huntington's that have psychotic features. I've seen many Huntington's patients with delusions, hallucinations, and I've seen two individuals who had the delusion that they were possessed by Satan. They had what we'd call diabolical possession, and it was a terrible factor in their lives. They couldn't get out of feeling that Satan was talking to them and telling them to do violent things. I think Huntington's is also very similar to the behavioral variant of frontotemporal dementia, and I'm sure that's because both diseases have abnormalities in the frontostriatal circuits. I think that makes a lot of sense. And the similarity to bipolar disease has also fascinated me. This is an ECT machine. I've had 3 patients with Huntington's who were severely depressed, and the psychiatrist caring for them decided to treat them with ECT. And 2 of them got remarkably better. It was really, there's no doubt that the ECT was successful, and their depression was greatly improved over a period of several months. And then they regressed. They were retreated, improved again, and then it was no longer of any benefit. That was 2 of the 3. The third one, it's clear that the ECT made him worse. His depression got worse, and his cognitive abilities got worse. And I have no doubt that the ECT not only was not valuable to him, it actually made him worse. So I think the story is out on whether ECT, how often it's useful in Huntington's patients with very severe depression. I don't want to make the whole talk be negative factors about Huntington's. I also have a table in my book, which is too small to read, but I've reviewed all the wonderful individuals and their highly happy and successful lives they had before they entered into the severe end stages of Huntington's. I've had doctors, lawyers, college professors, teachers, artists, cabinet makers, musicians, all of whom have had very successful years before they developed symptoms of Huntington's. They've been highly contributive to society. I particularly wanted to point out this man to you. He came to our clinic at age 91. He had been a Navy veteran in World War II, and then a very successful businessman.
I had 25 years at the paint tape company in Seattle, and I had, had stores in Seattle and Denver and Portland and Vancouver, BC. And
so that's just to show you his movement disorder. But I wanted to reiterate that he was 91 years old, and he had the onset of these movements probably in his mid 80s. He had very good cognitive function, and he actually just died earlier this year in a retirement center with Huntington's disease, and he also was positive for COVID-19, so that may have had a factor in his demise. But he died at age 93, and the point is he had 80 some years of a highly successful life. He's the oldest Huntington's patient I've ever seen, and I'd be fascinated to know if any older person has been seen elsewhere. He had 39 CAG expansion. In summing up, as I think back about my patients and the families, I've been impressed that the three key things to have in caring for Huntington's disease is compassion, determination, and patience. Compassion for the patients and their families, and not giving up. I found the Japanese word gamon, I think that's how you pronounce it, which I learned the definition of, and it was the impressive ability to endure the seemingly unbearable with patience and dignity. And I think that's reflects a lot of our Huntington's patients and families and how they cope with the disease. And finally, this is my last slide. I wanted to end with this. Speaking of successful careers, the man in this picture was one of our Huntington's patients, and he had a career as a highly successful professional fashion model. And in his early 20s, he actually appeared on the cover of a very well-known American magazine called Esquire. And he was in his 20s at that time. At this time, he had no idea that his mother had Huntington's disease, but she did, and she died of it. And he eventually came to our clinic many years later with the disease, and he passed away with the disease in his late 40s, actually. But that didn't interfere with his highly successful career as a professional model. And I thought it would be a sign of hope for the future to end with a Huntington's patient sending us an embrace and a kiss to end the session. Thank you very much for your attention.
Thank you very much indeed, Tom. That was a really lovely way to finish our conference, and we really appreciate all those very thoughtful views and stories. So thank you. I just wanted to read out one comment that's come through from James Valvano, who says, as an HD patient and founder of wehaveaface.org, your book has helped me and so many in our community. You validate what we experience as patients and caregivers. You truly understand us. Thank you.
A very kind comment.
And a similar, in a similar vein from Herwig Langer, who says, an outstanding expert sharing valuable information on the many problematic aspects of HD, especially on the side of the medical profession and society. So I think we can start the roundup session now. Actually, I just wanted to start, Tom, by saying I was very interested in what you said about the subdural hematomas, which are, of course, still problematic in HD. And one thing that we found in our patient cohort is that there's a tendency for health professionals outside of, who aren't working in HD and don't know it so well, to put down all symptoms that patients get to HD. And I wondered whether that's something that you've come across as well. So in other words, you know, non-HD problems can sometimes get misdiagnosed or missed in that way.
Yes, I mean, so if people come into an emergency room, for example, with a subdural, and nobody realizes that they have HD, or they come in with other psychiatric or behavioral complaints, for example, and it's never recognized that they have this disease, and they're often shunted off into a part of the medical care system where they shouldn't be and aren't getting the kind of treatment that they really deserve. In our country, because of their behavior problems, as I've tried to point out, they often end up interacting with the police. And you can imagine the knowledge of a police department about Huntington's disease. They usually know absolutely nothing about it. And so they end up in jail for inappropriate reasons, and may stay there for days, weeks, or months. And their care is totally inappropriate. They shouldn't be there. And no one understands who they are, what they have, and what ought to be done with them. It's very sad, but we're making a big effort to try and educate our police departments about this disease, and we're having some successes, actually.
That's really interesting.
I've been very much impressed myself about your talk, and it does indeed. There are many people with exactly what you said, with abilities for arts, and they actually do keep it even during the disease course. Of course, they might be not teaching anymore, but you will see. I remember one patient who was still painting, and he was still painting a long time into his disease with cognitive disorder. Actually, many of his paintings are still hanging around. In the meantime, he has died. I would like to ask you a question from your very large experience. How do you feel about this expressed quality of life people have in the later stages of disease? Of course, you mentioned the ones in the jails and so on, but we also have quite a number of people where I feel they increase their quality of life, even if objectively you look at them and they lose a number of functions. Do you have any comments on that?
Yes, I agree. I think we often misinterpret and underestimate the individuals because, particularly as physicians, we often see them as their disease, and they don't see themselves that way. They're in their own minds and in their own bodies, and they may feel that they're doing fine and they're doing well, and in fact they are. And we need to back off a bit and recognize that they're actually still functioning at a level that they're pleased with, they're happy with, and is actually still making a contribution to their families and society. And we need to recognize that. And just because they have some movements, or just because they're depressed, or just because they have occasional OCD symptoms, doesn't mean that they can't be very happy and contributing to the larger society.
And to us as well. I have, I don't know what your experience has been, but I have been laughing at many occasions with people in my clinics with HD. And so they have terrible HD, but we were laughing at topics together intensively.
Well, I have a patient I'll never forget, that she always would come in laughing and smiling. And she had what she called the HD handshake. And so, you know, you want to do a high five with her, and she would want you to do a high five. And so you do a high five, and she would always miss. She would miss your hand on purpose. And then she would laugh uproariously. And she would say, that's my HD high five. And she was enjoying it. She had a sense of humor and was having a good time.
If we try to make a link with our conference here, and to try to integrate on what we have heard, and this was really, we have been hearing tremendous interesting new findings and new ways of looking and assessing the disease, and of course all these new findings in terms of translational research and also on clinical research. Would you like to highlight some of the things we have been hearing or seeing recently?
I jotted down 3 things that I particularly was attracted with today. One was I really enjoyed discussing sleep in HD, because that's a huge problem for the patients. Disrupted sleep is a major problem in their lives. So I really enjoyed hearing that there are people investigating that and looking at that, and hopefully we'll have better ways of improving the sleep of people with HD. I was fascinated by the talk on cholesterol and cholesterol metabolism. I hadn't really thought about that, and I really enjoyed that discussion. And who knows, that could even conceivably move to some kind of treatment for the disease. You know, you don't have to treat the genetic defect in order to improve a disease. Like L-DOPA and Parkinson's disease, L-DOPA makes people with Parkinson's dramatically better, even though it's not addressing the death of the neurons in the substantia nigra. So I thought that was really quite fascinating. And then to hear about genetic treatments that may be either oral or intravenous, also I find extremely hopeful. It would be a lot nicer to have a treatment where you don't need a spinal tap every few weeks. So I was very glad to hear that kind of research is going on.
Okay, I wonder whether Astrid would like to come in on this as well. Do you have any highlights of your own, Astrid, and what do you think these sort of big opportunities and challenges are going to be from the patient group point of view?
Been 3 really inspiring and great days, I think, and super interesting. And I think, Tom, you gave a great last talk to this, and your question, can you help me? So on behalf of the HD community, the answer is you can help me, all of you out there. You may not be able to cure us, or you may not be able to have the golden standard resources to provide everything that we would want would want to do. But still, something is so much more than nothing, and your, as you say, the compassion and empathy and patience can help a lot. So that's one thing. That's with whatever resources you have, we can help and support each other. And the other thing that's really come out of this conference is re-encouragement. I mean, we had some hits from the setbacks from the Roche and the WAVE trial earlier this year, and and many people have felt really depressed after that, and maybe lost some hope. And I feel really encouraged and able to provide renewed hope. The work is ongoing and progressing despite these setbacks, and maybe also because of the setbacks, because there are valuable learnings made. And despite the pandemic, I think it's fantastic. And I think it demonstrates the capability and the strength of this community and the stakeholders, that we will not give up, and things really move forward.
I like your comment, Astrid, because of the setbacks, which I think is really pertinent, because in a way we're having these sort of setbacks, as we call them, because there's so much activity, and there will always be bumps in the road, and it's a sort of signal of the amazing progress that has been made over the last decade or two in this condition.
And you learn from every one of those setbacks. They're not just setbacks, they're not just failures, they are also learning experiences.
Yes, and also all this exchange which is around now, like between the companies who like to share their data and help one another in a pre-competitive way. Of course, later it will be different. Hopefully it will be different, because we have compounds and they will be in competition with one another. But at this point of time, this sharing and all this, what we have just heard before, this consortium where pharmaceutical companies and all the stakeholders are participating, I think this is also very encouraging.
Indeed, and it's definitely also the will, I'm sure, of the participants from these trials, that the data should be used to the best, whatever it can be, regardless of the result of the trials so far. So that's really appreciated and welcomed. I also think, if I may add, one of the take-home messages from this conference, again, is the reinforced focus on how can we enable ourselves or the community to do trials as early as possible. I mean, before you really have clear symptoms. And the last talk from Cristina Sampaio about this new staging system, and how can we measure where we are at the stage really early with only very subtle signs or biomarkers capturing it. And I think that's really something that we need to of course continue and be able to. It makes sense if we can treat people very early, then it's the better. The earlier the better, and that's also encouraging to learn that progress is being made here.
I can see that another issue is going to arise in Huntington's treatment that has already arisen recently in Alzheimer's treatment. And that is the issue of, do you treat the biomarker or do you treat the patient? And I think we all, want to treat the patient. I think that's the key. But it's very hard for both clinicians and for scientists to back off from this idea that if you have a biomarker that might be involved with the pathogenesis of the disease, shouldn't you be treating the biomarker? And will that halt the pathogenesis of the disease? And in some cases, that's probably the case. But I think you have to be very careful not to be trapped by treating a biomarker, which really doesn't have a downstream effect on the disease. So I think our focus should be treating on the disease. And for example, I think the treatment that eventually failed for Huntington's would probably have been approved by the FDA 2 years ago, when they showed that it was reducing Huntington in spinal fluid. They would have said, oh, that's a biomarker, that's directly related to the pathogenesis of the disease, so we'll approve it. Whereas the treatment trial failed.
I completely agree with what you said, but as well, we are encouraged to see, and we had very good examples during this conference, that people also do research and involvement in care, in care pathways, in organizing care, in also improving improving learning for people who do care, and as you said, also explaining to policemen what HD is. So there is a lot going on there as well, and this is also very encouraging. And I think even if you do not have now the perfect treatment at this point of time, when this is coming at some point of time later, it will be still have to be embedded in a care setting. And if we do good now, we add these new treatments, then will be even better. But this part here will still be needed, the care.
Yes, absolutely.
That's very true. You know, some years ago, I was thinking, oh, one day we will wake up and have the treatment, and then everything could just, you know, be pulled down because we will not need it anymore. And then I realized, well, it's not exactly the case in cancer or diabetes or other diseases where we have a lot of treatment, efficient treatment, and still we need good care and follow-up from the healthcare system and from the community in general. So that's definitely, we will never be out of work, I think.
Sure, that's true. And thank you. Thank you. On that note, I think we'll have to wind this session up now. We really appreciate you staying on and having this discussion, and for those very wise words.